Hello, Dr. Amanatullah. How are you?
Hi, I'm doing great.
Thank you for coming on again. Let's talk a little bit about joint replacement on the elderly community. First of all, and this might sound silly, but who counts as elderly when you account for how you're going to do the procedure and other things to take into effect?
Yeah, so it's actually a really good question. I think in general, people think of elderly patients as people over 75, but for me, it's very different. I wouldn't necessarily judge a patient by their age alone. There's good data in the orthopedic literature that patients over about the age of 80 do carry slightly higher risk. But I can say from looking at my patients and overall that if I had a 45-year-old who had many, many medical comorbidities, meaning, say, blood clots or lupus or, a bunch of issues that are going on, you might find them physiologically healthy, less healthy than a healthy 80 or 90-year-old. So for me, I think less about chronologic age and think more about a patient's physiologic age. And it's really the medical issues related to those patients that drives whether they're a good, bad, or indifferent candidate for total joint replacement because it controls the risks of the complications they might have. It just so happens that a lot of medical comorbidities come when we're older. So those things could be related, but I would say they're not related in every single case. And I would caution people from thinking just about chronologic age.
When you go in to do a joint replacement on someone with a high physiologic age, whether that's as a result of their actual age or some other comorbidities you were talking about, what are some of the additional factors you have to take into account when you actually go in on the consult, the surgery, and the post op?
So I think the things that we're looking at again are related to medical comorbidities. We want to make sure that everything is optimized for surgery. And the reason we want to do that is surgery is a big stressor. It's going to put all of these medical comorbidities at their worst, basically. There's a saying that basically once a patient goes to sleep or goes under anesthesia, their physiologic age manifests itself. So any liver disease, any heart disease, any coagulation issues, any renal kidney issues, we want to make sure that those are all optimized. Other things too that you might not think about we want to be optimized might be treating a disease that's gone untreated for a while, like hepatitis C. You can use Harvoni now to treat that. Or talking to people about their habits that are contributing to their medical issues, like obesity, like smoking, like alcohol. And because those are things that we can intervene on more readily than the disease itself. Additionally, want to talk to patients about psychiatric disease and how that might affect their satisfaction with joint replacements. So it's really a process of optimizing these patients to make sure that they understand how their medical issues interact with their surgery. During the surgery, for me, I think there are very few things that I can actually change, but one big one is blood loss and time of surgery. So the sicker the patient is, the less blood loss we want to have. We have lots of tricks currently. One great trick that's come on board over the last decade is something called tranexamic acid. It's basically a drug that we can give you that prevents blood clots from breaking down, and people lose dramatically less blood. I think it's been years since I've done a transfusion on a primary joint replacement. So I would say that's one of the biggest changes. And then the type of anesthesia. So spinal anesthesia versus general anesthesia versus blocks and injections. So we want to try and use all those things at surgery to make sure that we lose the least amount of blood for the best result. And then post op, it's really about watching the medical comorbidities we optimized. So if a patient's at high risk for an arrhythmia, we want to watch for an arrhythmia. If a patient's at a high risk for a breathing issue, we want to be really close by and make sure that we have a respiratory therapist there and we maybe have a short trigger to put that patient in the ICU. So it's about anticipating how the surgery could affect those medical comorbidities to keep everybody safe.
Now, we've talked a lot in the past about physical therapy and what it will take to get a patient after surgery back up to their optimal functionality. Now, that's going to look different for someone who is elderly, either physiologically or in terms of their actual chronological age. How does the recovery or physical therapy process look different for someone who is who is older?
Yeah, so I think that this is a great question. And I think all of us, again, assume that the recovery will be slower because of a patient's age. I would think about this a little bit differently in that, again, that spry 90-year-old versus that deconditioned 45-year-old, it really depends on how immobile, how deconditioned, how much activity that person was doing before surgery. What you can imagine is your preoperative level of function is going to determine your immediate postoperative level of function. So if the pain in your hip and the heart disease are stopping you from getting out of a wheelchair, then it's going to take a long time to recover from that wheelchair to a cane or nothing, because it's the buildup of the strength and the buildup of the conditioning that the pain-free joint gives you. So the joint itself isn't magic. The joint doesn't give you strength. The joint doesn't give you balance. The joint doesn't give you endurance. That takes time. And that really gets at the level, how low or how high that patient's function is before surgery. That just tends to sort with patients who are elderly in general, aren't doing a lot of activities, maybe related to medical comorbidities or other issues. So if an elderly person comes and they are deconditioned, then absolutely their trajectory will be slower than a person who's not. But the same concept applies to that 45-year-old. If that 45-year-old's medical comorbidities stop that from exercising, just changing the joint isn't necessarily going to change the trajectory of their recovery.
In your experience, what is the number one fear that elderly people come in with when they have to undergo surgery, and how do you put that to ease?
Well, I think they come with many fears. I think one of the biggest, most immediate fear is falling. And that is a big risk. I think there's really not been any great interventions to prevent falling. And so that's a huge issue for them. I think the biggest one is for us to remind them and for them to be conscious and to not push the patients. It's not a race. It's really a marathon that we're going to start with surgery, and they need to understand that we just need them to finish the marathon. We don't necessarily need them to sprint to the end. I think that's where people get into trouble. Other fears that they have is that, look, I might not live that long. I don't need a joint replacement, or I don't want a joint replacement per se. So I would say is nobody needs a joint replacement. I think I've expressed that before. But how you view your life may change whether you want it or not. What I would say is if a patient's having a significant amount of pain to curtail their activities of daily living, and their life expectancy is longer than a few months, they would easily benefit from that hip replacement, meaning you'll be 80 to 90% better at 3 months after the surgery. So that's a tremendous amount of pain relief. So I think that a lot of times they're thinking about this as a long-term thing as opposed to a pain relief issue. The final thing that they're concerned about centers around that is the medications that they'll have to take on top of medications that they have previously. And finally, kind of what level of activity they can expect to get back to. And I think those are all really covered in previous talks, but I think that in general, pain we can control quite well without the utilization of narcotics, and those narcotics can make elderly patients sleepy and predispose them to falls, confusion, etc. So we really want to avoid that. And with respect to activity, we tell them we're not going to limit you at all. You can do whatever you can possibly do, just to don't push yourself so hard to avoid falling. And in that way, we can kind of optimize the risks that they're concerned about versus the risks of the surgery. The final thing they come in worried about is that they're so old. So I have a patient who was 112 years old, 100 and no 106 years old. Sorry, 106 years old, and we did a total knee on that patient. So it's not, they're worried that the surgery itself is going to cause them to die. That's definitely not the case. I mean, the surgery itself is quite safe. It's really the stress the surgery places on their medical comorbidities, again, and how well we can optimize that scenario.
Awesome. Well, thank you so much for sharing. I really appreciate it.
You're welcome.